In this voiceover, I will be addressing the specific types of cancer of leukemia and stomach cancer, and then the different subtypes of leukemia as well. It's important to know these as you will be seeing them at different points in your career. However, there probably won't be too many test questions over these two different types of cancers. The exact cause of leukemia is really unknown, although many genetic and environmental factors are involved with regards to the increased incidence of leukemia. So you notice I've mentioned genetics, environmental factors, and primary immunodeficiency reasons. For genetics, having Down syndrome, Klinefelter syndrome, Bloom syndrome, or Fanconi anemia can cause an increased risk due to DNA mutation with the bone marrow and that white blood cell and red blood cell creation. With regards to environmental factors, a lot of times we will see a lot of leukemia patients here in the Valley related to these specific types of factors, but you have an increased risk if you're exposed to ionizing radiation or different types of chemical exposure, so any types of carcinogens that could alter DNA mutation. So patients who previously in the past have had radiation therapy could potentially have an increased risk of developing leukemia later on in life. Something to consider, certain chemotherapies as well could potentially cause leukemia later on down the road because it is somehow altering the full body DNA mutation. So essentially, it's something that affects the whole DNA mutation systemically. You could also have issues with primary immunodeficiency. We see a lot of patients with the diagnosis of myelodysplastic syndrome that later on develop leukemia in life. So treatment of myelodysplastic syndrome is really important to prevent that proliferation into leukemia. You can also see Fanconi anemia causes an increased risk for primary immunodeficiency issues as well. There are many different signs and symptoms of leukemia. It's important to note that many of these signs and symptoms can easily be diagnosed or referred to because they mimic a lot of other signs and symptoms for other disease processes. So it's a systemic effect on the whole body. It's difficult to tell. There's not really as much of metastasis because it is a systemic effect. So essentially you could have some neurologic changes. Fatigue could be like that neurological, psychological changes because of anemia. You could have fever related to infection because remember these patients are immunosuppressed. They could have headaches due to increased white blood cells infiltrating your CNS, so your intracranial pressure could be increased. It could also be due to malnutrition. They have lots of skin changes. These patients will frequently, even before chemotherapy, start exhibiting night sweats. They will have petechiae across their chest, easy bleeding or bruising. A lot of times this is why they come into their primary care providers because, hey, I've been diaphoretic, I'm bleeding and bruising easily, and they run a CBC and note some abnormal lab values. They can have enlarged organs, so splenomegaly or their liver is enlarged just because of increased white blood cell, red blood cell production or difficulties filtering out the altered red blood cells. You may see issues with bleeding, anemia, issues with weight loss. It's a huge GI symptom. They just can't keep on the weight, so it's unexplained. Frequent infections. So you could have a patient who comes into the ER, they just can't get rid of this sinus infection. They've chronically had it, and they run lab values and realize they have leukemia and they're immunosuppressed, and there's a reason why. Or they'll come in with dental caries that cannot be resolved, and so they need quite a bit of dental work, but you notice that they're having issues with bleeding in their mouth. Those sites aren't healing, and a lot of times it's because they have leukemia. Issues with weakness, pain or tenderness at the joints. So many of these signs and symptoms may mimic other disease processes. You can read a little bit more about them in your IGGI text as well. So biggest diagnosis, of course, is always going to be biopsy, and this occurs through bone marrow aspiration. Very painful. Essentially, you're sticking a very large trocar needle into the bone marrow to aspirate and determine the specific type of leukemia, which can help determine type of treatment. A lot of times they are initially diagnosed based on values from their CBC, and then they're referred to an oncologist for further follow-up. You can also tell their absolute neutrophil count when they come in, which is based off of your white blood cells, your segmented neutrophils, and your banded neutrophils. So this ANC number, you can see there's a calculation below. You're not expected to know this for the final. It's just good to know. Normal ANC, I have on the slide, it says greater than 1,000, but pretty much normal is anything greater than 1,500. 500 or less is fairly severe neutropenia. So you really want to monitor these patients closely because they're very immunosuppressed. Essentially, prevention of infection and prevention of bleeding is going to be priority in these patients. So there's several different types of leukemias. The most common in children is going to be your acute lymphocytic leukemia. It's often diagnosed between ages 2 to 4 years, and typically if they receive treatment early on and have an early diagnosis, they can achieve 90% remission, and often they do not have any relapses in remission, which is fantastic. The most common in adults is acute myelogenous leukemia. Typically occurs between adolescence and kind of after age 55. Prognosis can be pretty good with treatment. You can achieve complete remission about 50%, which is not very good values, but that's a lot better than some of the other leukemias that can occur. Pretty much they have issues that stem from your myeloid stem cells, which cause that white blood cell and red blood cell production in the bone marrow. You can have chronic lymphocytic leukemia. Chronic meaning that there's really no remission or cure from this. Survival time is about 4 to 5 years. Typically occurs in 35 to 50 year age range. And chronic myelogenous leukemia typically occurs in your 30s to 40s. Pretty poor survival rate if you end up with a diagnosis of CML. Only about 30% survive to the 5 years of cancer diagnosis. Biggest treatments for leukemia include chemotherapy induction. So prior to chemotherapy induction, these patients have to go through quite a bit of testing to ensure that they're healthy enough and able to get through an induction process. So essentially these patients are admitted inpatient for a month or longer to go through this process. Their lab levels have to be at a specific point. These patients, you have to treat any active sites of infection. So if this patient comes in and they have a whole bunch of dental issues, you have to treat this before you go through induction, because the purpose of a chemotherapy induction is to get them to the point where their ANC is 0 to help kind of restart or reboot the bone marrow into producing full white blood cells and full red blood cells. After they achieve induction, they can achieve a remission status, and then they will undergo maintenance therapy for several years. During chemotherapy and even prior to chemotherapy, because of the patient's lab levels, they'll receive a lot of blood and platelet transfusions. Typically, physicians can create range orders for these patients, which makes it nice because you're not calling the doctor every day for blood orders or because of critical lab values with regards to blood and platelets. For this blood, typically they'll create an order like infuse, 1 unit of blood if their hemoglobin is less than 7.5. Or infuse 2 units if their hemoglobin is less than 7. Typically, these patients are blood banded, and those blood bands last for about a week. So they're already blood banded, you're all ready to go to get administered blood. Because they're so immunosuppressed, you have to have special types of blood, which can be difficult to get in such rural areas like Idaho. So typically their blood will be not only their blood type, but it has to be CMV or cytomegalovirus negative and irradiated. So very difficult to come by. Same with your platelets. These patients can undergo radiation as well. A lot of this can help with pain management and more palliative approach. Apheresis would take your red blood cells and put them through a machine, and essentially you're getting back your full red blood cells and taking away those immature ones. They will be on several different types of medications related to chemotherapy, pain management, antibiotics, prevention of tumor lysis syndrome. They'll be on multiple medications, including prednisone. Now, it seems contraindicated because prednisone can cause immunosuppression, but it actually helps prevent inflammation or overstimulus of those white blood cells. And then a lot of times to help them achieve remission, especially for an acute myelogenous leukemia or acute lymphocytic leukemia, these patients will undergo stem cell and bone marrow transplants. A lot of times they can be autologous, meaning they receive their own bone marrow. but a lot of times they receive it from a donor as well. Again, any issues with transplants could occur with these types of stem cells or bone marrow. However, these patients have to achieve, again, an ANC of 0 before they can end up with a stem cell or bone marrow transplant so that their body doesn't reject those transplants. Next, we're going to be going into stomach cancer. There is a high incidence of stomach cancer in African Americans in the Oriental population, most likely due to poverty or a diet. Men are typically 2 times greater than women to also get stomach cancer. Age increase. The older you are, the more likely you are to be diagnosed. Kind of like we talked about, age is one of those most important risk factors. And typically, the majority of stomach cancers are specifically adenocarcinomas, which also occur in lung cancer and other parts of the body. So huge risk factors, H. pylori bacteria. So H. pylori bacteria is often common in ulcer formation as well. So if you have a high incidence of ulcers caused by H. pylori, you're at a higher risk of stomach cancer. If you have a huge increase in polyps, again, depending on populations, if you eat a lot of pickled or smoked foods. So I would encourage you to eat lots of fruits and veggies. Tobacco and alcohol intake, of course, are increased risk factors as well. So often, stomach cancer is not diagnosed until metastasis. These patients don't exhibit signs and symptoms. So really the only type of diagnosis is going to be biopsy through endoscopy or colonoscopy. So if these patients are undergoing a routine colonoscopy, they may see a tumor growth or a polyp that they can biopsy and determine this type of stomach cancer. But you can often see fatigue, nausea, vomiting, weight loss, dizziness, anemia, which are common signs and symptoms you can see with many other diagnoses. Late stage, they may actually have a palpable mass, increased pain, lethargy, etc. Biopsy will help determine the type of treatment or the type of stomach cancer that these patients have, but they will need a CT, a PET scan, or ultrasound to determine the extent if there's metastasis or to stage the type of cancer. So, biggest types of treatments. Again, you can have the 3 most common: chemotherapy, radiation, and surgery. Many of these are used as adjuvant therapies, meaning they're used together. Chemotherapy and radiation therapy can often be used sometimes as a palliative approach for patients, just to make them more comfortable if tumor size is causing many side effects. It often can be used to help debulk a tumor as well prior to surgery. Typically, prior to this, they're going to get a lot of different lab levels as well prior to surgery. Again, so same chemotherapy, radiation precautions apply to these patients. Different types of surgeries. I'm just going to briefly go over them. A lot of the side effects from these surgeries are going to be similar to those that occur with those bariatric surgeries. So issues with dumping syndrome, they're going to have NGs, what to do with regards to diet. So in the right-hand side, you see several pictures. There's the Billroth or Billroth 1. Essentially, they remove the lower portion of the stomach where stomach cancer will most commonly be found. And they anastomatose or attach it to the duodenum. The Billroth 2 is a little bit more extensive if they have cancer that is more concentrated around the antrum and distal portion of that stomach. So they will take that and anastomatose it to the jejunum, so another part of your intestines. And then with the gastrectomy, they actually remove 80 to 90% of that stomach. And so they've kind of formed their own little pouch with that. And then that last one, you can have your entire stomach removed, and pretty much your intestines are anastomatosed to your esophagus. So you can imagine the different types of digestion or eating issues that can occur from these surgeries. So biggest nursing management post-op, you're going to watch strict eyes and nose for these patients, especially in their NG. So monitoring the amount of drainage they're having, how much urinary output they have, of course, post-op. They shouldn't be having any bloody vomiting. They shouldn't be having any bloody stool as well. So remember, post-op surgical complications are still the same. So pulmonary emboli, DVT, pneumonia. You want to make sure you're using that incentive spirometer. You're encouraged, early ambulation to get them moving. You want to make sure you're monitoring their weight as well. These patients are at a high risk of being malnourished, especially because you're starting the diet slowly, but their digestion process is really going to change quite a bit. I would review dumping syndrome from your bariatric lecture as well, especially the signs and symptoms. It's a pretty normal complication post stomach surgery, but essentially your stomach contents abruptly empty into the duodenum just because you're overfilling too fast or eating too fast or taking in too much fluids. So essentially, diet-wise, they're going to start slow. So ice chips only. If they still have an NG tube that's suctioning, they're most likely still going to be NPO. But ice chips, maybe clear liquids. You want to encourage them when they're eating meals that they don't fill up with fluids first, because you want to ensure that they're getting adequate caloric intake and ensure that they're not getting malnourished, because they're not going to have a very large stomach. You want to make sure you're also watching for, again, post-op bleeding, signs and symptoms of infection. And that is kind of the end of our Cancer 2 lecture on the different types of cancer. We kind of focused on the main cancers that you will see in adults. There's obviously quite a few more different cancers. But essentially remember, your biggest treatments are going to be chemotherapy, radiation, or surgical management.